Hi all. In this video, we're going to see some important physiological basis questions that can be asked from gastrointestinal system. So in this video, I'll be basically dealing with the physiological basis questions that can come from the GI motility part. Okay, so let's start. So the first question that is very important is deglutition apnea. What is deglutition apnea and what is the physiological basis behind that? So we know that during swallowing, temporarily during the deglutition reflex, the respiration is stopped. So that is called deglutition apnea. And this is because the swallowing center, which is the main center which is required for swallowing, inhibits the respiratory center. So deglutition apnea, during swallowing, there is a temporary cessation of breathing known as deglutition apnea. This is a protective mechanism to prevent the aspiration of food into the trachea. The process is controlled by swallowing center in the middle oblongata, which inhibits the respiratory centers during the swallowing process. So that is the cause for deglutition apnea. Next is the physiological basis of receptive relaxation. So what is receptive relaxation? See, normally when there is no food inside the stomach or when the stomach is empty, the stomach is like this. But once we start having food, there is a relaxation of the stomach, especially the fundus and the body part, so as to accumulate or to accommodate the food that is entering the stomach. So that is meant by receptive relaxation. Now, what is the physiological basis for this receptive relaxation? That is done by the vagus nerve. So when food enters the stomach, the vagovagal reflex is activated. That means the food distends the stretch receptors that will send the information to the vagus, and via the vagus itself, the stomach relaxes. So that is why it is called vagovagal reflex. It causes the stomach to relax and expand without increasing pressure. So this is known as receptive relaxation. And which are the neurotransmitters that are related to this receptive relaxation? Obviously, it must be a neurotransmitter which it should be an inhibitory neurotransmitter like the nitric oxide and the VIP. That is why there is relaxation of the muscles. So these neurotransmitters relax the smooth muscle in the stomach and thereby is important for accommodating large volumes of food. So the basic physiological basis behind receptive relaxation is this vagovagal reflex, which releases these neurotransmitters. Now the next question is, why is dietary fiber advised in diabetes mellitus? What's the physiological basis behind it? So we know that in diabetes mellitus the problem is we have spikes of increased blood sugar. So dietary fiber, especially the soluble fiber, slows the digestion and absorption of carbohydrates by forming a gel-like matrix in the gut. So this will delay gastric emptying and reduce the postprandial glucose spikes. And it also improves the insulin sensitivity by modulating the release of incretins such as glucagon-like peptide 1, which helps to regulate blood sugar. So basically, we advise diabetic patients to include more dietary fiber because first of all, it will help in delaying gastric emptying, thereby reducing the postprandial glucose spikes, and also improves insulin sensitivity and thereby helping the blood sugar. So why does it delay gastric emptying? Because they form a gel-like matrix in the gut. So this is why we advise dietary fibers to patients with diabetes mellitus. Now why is it advised in constipation? So in constipation, what is the problem? The GI motility is decreased. So that is why the undigested food is not released into the exterior. So we advise the patients to have dietary fiber because it will add bulk to the stool by absorbing water, which stimulates the stretch receptors in the colon, and that can enhance peristaltic movement through myenteric plexus. See, when the abdominal wall is stretched, the stretch receptors will be activated, which in turn will send the impulse via the myenteric plexus to stimulate peristalsis. So this dietary fiber will add bulk to the stool so that it can stimulate these stretch receptors. So this increased motility will help to propel the stool through the large intestine more efficiently, reducing the risk of constipation. So that is why we advise dietary fiber in constipation. Next question is, why does peristalsis precede oral to aboral end in the GIT? So we know that this is called the law of gut. That means peristalsis always proceed from the or goes to the oral to the aboral end. So why? Now that is because, see, we know that this is the diagram showing that myenteric reflex, wherein you can see that when you have a bolus here, it will stimulate the stretch receptors, which in turn will send the information to the myenteric plexus. And there, the area just before the bolus is contracted by releasing the neurotransmitter acetylcholine, and the area which is just above or in front of the bolus is relaxed by releasing the neurotransmitter nitric oxide. So it is because we have definite direction of the myenteric plexus and we've got definite neurotransmitters that are released, and thus the bolus will go only from the oral to the aboral end. So the law of intestine governed by the myenteric plexus explains the peristalsis movement of food in one direction from the oral to the aboral end. The myenteric reflex ensures that when the gut wall is stretched, the smooth muscle behind the bolus contracts while the smooth muscle ahead of the bolus relaxes. This coordinated movement pushes the food towards the rectum. So that is the basis behind why the peristalsis proceed from the oral to the aboral end. A next important question is, why is lower esophageal sphincter always in a tonically contracted state? See, we know that in order to prevent the gastroesophageal reflux, the lower esophageal sphincter always has to remain in a contracted state. Now, how does that occur? That is because we have neural inputs from the vagus nerve as well as local myogenic activity that always maintains it in a contracted state. Now it's only during swallowing that the lower esophageal sphincter relaxes, and that relaxation is mediated by inhibitory neurotransmitters like VIP and NO. All other time it remains constricted because of the vagal inputs as well as the local myogenic activity. Another important question is, why is there passage of feces in infants immediately following feeding? See, in kids we see that as soon as they have food, there will be immediate defecation. Now this is because of a reflex which is called the gastrocolic reflex, in which the distension of the stomach of food leads to increased colonic motility and passage of feces, and this is especially strong in infants. That is why there is passage of feces immediately following feeding in infants. Another important question that can be asked is, why do some anesthetics cause vomiting? For that, we have to know the basic mechanism of vomiting. So see, this is a flow chart which shows that basically we've got a brainstem vomiting center which can be stimulated in various conditions, like when you have motion sickness or vertigo, when you have intense pain or some sights or anticipation. All these can stimulate the brainstem vomiting center. Now along with that, we've got another important area called the chemoreceptor trigger zone, which is present in the area postrema. Now this is a very important area which is direct influence to the brainstem vomiting center. So you can see that there are many drugs and hormones which will stimulate this chemoreceptor trigger zone and thereby stimulate this brainstem vomiting center. So this is the reason why anesthetics may cause vomiting. Certain drugs can cause vomiting because they stimulate this chemoreceptor trigger zone, which in turn will stimulate the brainstem vomiting center. So anesthetics can stimulate the chemoreceptor trigger zone in the brainstem, which sends signals to the vomiting center, causing nausea and vomiting. Additionally, anesthetics may disrupt the gastrointestinal motility, leading to gastric stasis and increased risk of emesis. So see here, anesthetics, because basically the anesthesia means there is a decrease in the neuronal transmission. So they can disrupt the gastrointestinal motility, and thereby there will be increased contents in the gastric lumen, and thereby there is increased risk of emesis. So that is why anesthetics may cause vomiting. So thus we've discussed some important physiological basis questions today. I hope this is useful for you. Thank you.